Welcome to the Soulful Surgeon Podcast with Dr. Lisa Hunsicker, a sanctuary for healthcare workers. In this space, we honor your stories, your struggles, and your triumphs. Here, you are more than your role. You are seen, heard, and celebrated. Join me as we explore conversations that nourish the heart, elevate the mind, and remind us why we chose the path of healing. This is your time. This is your place. This is the Soulful Surgeon Podcast. Hi, everyone, and welcome to the Soulful Surgeon Podcast. I'm your host, Dr. Lisa Hunsicker, and this is the place where healthcare workers come to be seen and heard. Now, we like to talk about all things healthcare, and sometimes it's funny, and sometimes it's maybe not so funny, and these are the struggles that we deal with regularly. Today, we have an amazing guest. Hallie Woods is with us. She is the CEO of Accessum Health, and she has 15 years worth of executive healthcare experience, but she's also been in the trenches with us the whole time. And so, Hallie, tell us a little bit about how you came to being the CEO of Accessum Health and what that journey was.
Thanks, Lisa. Yeah, absolutely. And first of all, just thanks for having me. I think the work and the message that you're sending out is really important. And I saw it working alongside doctors such as yourself and healthcare workers in general. But I like to say the very first healthcare worker that I ever knew was my mom. And she was a nurse. She was a nurse for 35 years. And like many nurses, kind of bounced to different specialties, but spent the majority of her career in the OR. And she really inspired me to go into healthcare because although, we never explicitly had the conversation, I understood growing up with her that she wasn't just, punching a clock, taking a paycheck. She was really taking care of people in their most vulnerable moments. And I wanted to offer that same thing. A little different though. I was really interested in processes and operations and how do larger scale healthcare organizations serve people. And so instead of the MD or the RN or whatever the initials of the many multidisciplinary the people that work in healthcare, I went and got my MBA and worked in healthcare administration. So as you mentioned, I spent, 15 years working in hospitals and rose up to chief operating officer and got to work along some really, really amazing people, cath lab techs and housekeeping staff, mechanics who served the hospital, doctors, administrators, people who all really show up every single day because they care about doing something for the greater good and for helping other people. Um, I really enjoyed that work, and I really felt pride and amazement during the pandemic when we all worked alongside people who literally put their own health and their own safety and their own family safety on the line to take care of other people. And so those are the type of people that I found myself surrounded with. The challenge I really saw, though, is the system that we worked inside of, this larger healthcare system, which is so complex and really set up around making profits and driving a business, didn't have the same alignment as the people that were working in it. And that really drove me to start to question, is this the right space for me? I want to help people. I think like myself, whether I'm on the business side or any of the clinicians here to serve, I really had the question of, I got into healthcare to take care of people, but is the system that we're operating in really aligned with that? And do we have misaligned incentives? Um, so that was one of my big challenges in healthcare, and especially as an executive, where I'm making decisions that then impact the people that I work alongside.
What was it like in COVID? I mean, because we were all, most of medicine was separate, right? We all went into hibernation for a short while, but only emergent medicine and certainly COVID medicine were going full throttle. But, you were there as part of that too. What was that like?
COVID was probably one of the most exhausting challenging emotional times of certainly my career and for many people as well. It was also the most rewarding. I never, as hard as it was, we used to, the cliche saying, we're building the plane as we're flying it. That's what we were doing in hospitals, right? We didn't have guidelines. The guidelines were changing every day. We didn't have literal infrastructure on how to take care of patients. I was working at a hospital with demographics in the very early phases of 2020 that had people who live in multi-generational families. They were essential workers, so people who weren't really able to isolate. So we saw a big surge coming in that first wave in 2020. And it took, our plant operations directors and our nurses and our respiratory therapists figuring out new ways to care for patients and do that quickly. But it was also really meaningful. I still remember just like a lot of people say when I was on quarantine and we'd be at home drinking, and I was like, oh, I did not have that experience.
I didn't have it either.
I think about being at the hospital 7 days a week, driving in at 6 o'clock in the morning because we had to be there early because we were setting up incident command for the day, and like nobody's on the road with me. And you just go and you just do it because you have to. And I remember this was on the news and stuff, so I'm not sharing anything I shouldn't be sharing. But we had a young gentleman, and I was at a hospital where we were doing ECMO, so that's the extracorporeal membrane oxygenation, heart-lung bypass. That we had a young gentleman, he's 40 years old, father of two young kids, got COVID, was sent to us from an outside hospital, put on ECMO, and really testy there, didn't know if he was going to make it, but he did. And after about 7 days of being on ECMO, he got to go home. Well, he's going to a rehab and then ultimately home. He's a healthy young guy, but some of the nurses arranged that we were going to have a big send off for him. He was our first real patient with a story like that. And I remember he came down the elevators of the tower, came out, and half the hospital was there cheering him on, and his wife was there. And I think that was like not a dry eye in the room. And that was like, okay, this is what we're doing this for. This guy who's going to go home and with his wife and his two kids are going to have their dad is why we are doing this. And I think, again, that's the type of person that you get in healthcare, people that want to do that type of work.
And what did you tell your family? Because at that time, in the hospital, if you contracted COVID in that very first strain, you weren't necessarily guaranteed to be alive at the end of it.
Yeah. I, I don't, it's a good question, Lisa. I don't know that we had an intentional conversation. I think it was just, this is my job. I have to do this. I signed up to work in a hospital and we have to take care of people. And yeah, I was nervous. I had two young kids, but it was, otherwise healthy. And I was pretty good about, wearing masks in the hospital. It's funny. I never contracted COVID in the hospital in the beginning. And, I got it through community exposure down the road in a later wave. But I think hospitals were really good about, you're in a group of people who know how to keep, the distance and wear masks and do things the right way, have protocols. And so even though I was really nervous about it in some ways, and I also understood that I was not as a business person. I was up on the units and walking through the ICU, but I wasn't in the rooms treating patients. And so, you know, I felt very like grateful to the people who are really putting themselves on the line by going in there, and doctors placing trachs and patients. And um but it's something that you think about of what if it's me? You know, I'm what if I bring this home to my family?
Yeah, I think that was a similar concern that we had in our family too, and especially since we are a two-surgeon family, and we were both on the unit working simultaneously. The question was, is what if we do bring it home? But even if we don't, do we orphan our, our family? We have a child. Do we orphan our son? And who's going to explain that to
Yeah.
him? Because he's a kid, right? And he's going to say, well, you know, I don't really care about all these other people. I'm just this
Yeah.
kid and I want you to be here. And how do you explain that, to kids? So I think it's a really difficult place in healthcare where we have to show up and we have to be there, but sometimes it does come potentially at the expense of us. And sometimes it's something very huge like COVID, but then many times it trickles down into so many other things. Now, so you're in healthcare and you're in this hospital system. What happened for you that made you say maybe this isn't the right place for me and maybe I need to start something different?
You know, as with any big life decisions, it's never one thing usually. And there are a few things that happened, and I think they're all relevant to our healthcare system and the challenge. The first was my mom, the one I just talked about, the nurse. I was at the hospital one day and I was giving a presentation to staff, and my phone started ringing and ringing and ringing. And um, I got through the presentation and I picked it up, and I had been getting phone calls from an EMS worker who had found my mom unresponsive in her front yard. Um, my mom was a healthy nurse. She, didn't drink. She exercised. She ate right, took care of herself, and we got to the hospital and she was gone. And she was 62. A 4 month old. My daughter was 4 months old, and my son was 2, and was really not expecting to lose my mom so young. And she had an unknown cardiac condition that she had been saying to me earlier on, I'm kind of short of breath. I just kind of feel heavy in my chest. Mom, go to the doctor. She goes to the doctor. The doctor says, oh, it's probably nothing. Let's just do a quick check. Okay, everything's fine, and pushed her out. And what we didn't know was that her heart muscle was dying. And at the time, I really thought about like, what should we have done differently? What should we have differently? And I thought, primary care, first of all, should have more than 10 minutes with a patient. I mean, our system right now pushes volume through. There's these economics of we need to fund profit. The business of medicine and healthcare are two different things. And because our industry is a profit-making industry, we're constantly looking at how do we maximize profit. And so that means less time with doctors. That means how do we focus on the sick people where the money is made and not on the healthy people. And so I really at that time thought of that of hers as a casualty of the system, and not an individual doctor. Then after COVID, lots of challenges started happening with the economics, and we heard, we saw a lot of challenges with healthcare expenses going up. Right, supplies costed more, that we were having to try and ship them. We all know there's massive supply shortage, drug shortages, everything started costing more. But hospitals, doctors, healthcare organizations get kind of predetermined rates from the government through Medicare and Medicaid, or contracts they have with United Healthcare, with Cigna, with Aetna, with Anthem, with all the different insurance providers. And so what you saw is same or less money coming in, expenses going up, and these compressed margins. And so what do when you can't affect your revenue? You go back and say, how do we cut costs? And as a COO of a hospital, I was having to make a lot of decisions that I didn't feel were were in line with my morals and values, but the morals and values of why people go into healthcare. That went anywhere from laying off employees that had worked for the organization for 40 years. That came for cutting jobs of housekeepers who kept the hospital clean and reduced infections. That included cutting back lab services, so lab draws didn't get done timely, and closing cafeterias when patients and their families need, the families coming and visiting patients on the weekends. And those are business decisions, right? Again, business and medicine. But I had a lot of tough conversations where I just said, this, I know, I don't know that I can stop it, but do I really need to be part of it? And then the last thing that kind of happened was, thinking back to my mom, I was driving home one day with chest pain, likely stress related. I knew at the now, in hindsight, 2020, and made me really nervous, knew about my mom and kind of said, I'm going to do things differently. I went to a cardiologist, I got tests worked up and, and did everything I should, labs, and everything came back normal. But in a CT of my chest, we found early stage thyroid cancer. Thyroid cancer is really treatable. And I've just felt really lucky because I got it caught really early. So a real simple surgery, moved on from it. But it just made me think, okay, I'm working in a system that's not helping people. I'm getting sick and I'm not being able to catch it, even with a Cadillac insurance plan, even with great access. This isn't right. And so I left and made the decision to leave and focus on my company, Accessum Health. We do everything from access and nurse navigation, but my goal in all of it was to help people not just get care, right? You can get care, but how do you prevent? How do you advocate for yourself? And as a healthcare worker, oftentimes we're doing that for our friends and family. And I thought that's unfortunate, right? How do we bring this to a larger scale? And how do we help more people actually achieve health, which is, I think, again, where most healthcare workers go into healthcare is to help people and help them be healthy, not make profits off them being sick.
Yes, I've been in that same situation many times where your family members and friends are saying, hey, I've got this issue and can you help me navigate? And I know that even in my own personal journey of my own healthcare and our family's healthcare, I live and breathe and work in it 24/7. And when I have difficulty being able to navigate it, it just compounds, significantly for all the patients who are trying to do this. They don't know how to navigate it, and we work in it, and we have trouble navigating it.
Yeah.
I don't know how to make that better for them, and I so appreciate what you're doing because trying to get people connected with healthcare providers. I had a patient similarly who had thyroid cancer, and it had gone missed. And through our series of pre-surgical workup, we figured it out. And it took this patient, well, she ended up leaving town and going out of state because it was going to be over a year before she could get an appointment to be able to get in. And she found someone in Florida as opposed to here in Denver. And
Yeah.
so she went out of state and was treated because she found a private group that did not have connection with a hospital system and had their own private setup, and she was able to get in and get treated. And that's fully insured. None of the financial barriers that many people have. She had full access from a financial standpoint. She physically just could not get in because
Yeah.
it just wasn't possible due to the backload. And I feel like there's this moral injury that keeps happening to everyone in healthcare. Tell me, what do you think about that? Do you feel like you've had any issues like that? And what have you seen in healthcare?
Yeah. I think it all goes back to, again, that or the reason people get in healthcare. It's usually because they want to help people. They're scientists. They really want to practice their trade. And then you have this system that's about volume and throughput. Um, and let me give an example because I think it's illustrative, and then I want to answer your question specifically, Lisa. But If I go to a primary care doctor, and you know this better than I, that primary care doctor is going to see me, going to bill the visit, going to make on average about $140. So that $140 is going to be what has to cover salaries, what has to cover supplies. That's not, that's their top line revenue. If I'm a health system, I know that's not a lot of money, right? Especially after I pay for everything. So I know, if I'm the CEO of the hospital, and these are things that decisions I had to make. I know that if somebody goes to one of my cath labs and has a coronary artery intervention, where they go in the cath lab and they either look and do a diagnostic look at the coronary arteries, or they do an intervention, I'm going to make somewhere between $12 and $60,000. Okay, so not too much difference in time, way different finances. So what do? If I know that primary care, I want to get more patients in my funnel to get to the cath lab where I'm going to make money, I'm going to back up and say, okay, 100 primary care patients yields about 3 referrals to a cardiologist. 3 referrals to a cardiologist gives me 1 patient in the cath lab. I got to get that 100 up much more. I got to increase the number of people. So I'm going to go to the primary care doctor and I'm going to say, I need you to see 30 patients instead of 20. And instead of 15 minutes, I want it to be 12. And I got to stuff that funnel. We got to get throughput. We got to get volume. And so what that causes is this rat race. And then you line that up with Medicare reimbursements going down. Physicians, healthcare workers are being pushed to do more with less time, right? The revenue is going down. The volumes need to go up to compensate for that. And it becomes this unsustainable environment of the hamster wheel of just like, I got to see 35 patients today. I'm in surgery. I've got to run to the hospital. And, I think most doctors, most nurses, part of the enjoyment they get about their job is that time with their patient, right? Whether it's in a patient room in a hospital, it's in a clinic, getting to know them, understanding, helping them. And then you take that away and it becomes, did you chart? Did you do all of the things you need to do? I read a stat the other day that said a primary care physician, if they did all of the recommended screenings and did all the required charting every single day, would need a 27-hour workday. It becomes this unsustainable, I can't keep up and I'm not giving the care that I got into medicine to give. And so, bad things are happening. We've had a few surgeons in the Denver metro area commit suicide. Mental health isn't always, I've worked at a hospital with one of those surgeons and we lost a very young, talented surgeon. Mental health isn't always talked about. It's even though there's, this ongoing effort, I think a lot of physicians and healthcare workers don't talk about it publicly because it might do harm to them and their reputation and their business. And so it's a real issue and it's not talked about enough. And I don't know that we know how to slow down this hamster wheel, but um, people should care. I think patients should care. These are the people that are taking care of them. I always say when I'm 85 years old, gosh, who are going to be the providers taking care of me? Are they going to be mentally healthy so they can take care of me? Are there going to be enough? Am I going to be able to afford it? These are
Do
real
you think it's
questions.
possible to even like with all these things, like you said, it's a 27-hour workday, which is not sustainable for, a human being, right? We have to sleep and we have to have time with our families. And I think we just have to be mindful of that. And I feel like we have the business where insurance and hospitals are recognized as businesses, but I do wonder if it's understood that all these private practices that house all these physicians and nurses and all of the ancillary staff are also businesses too. And, much like, with all the rising costs, you go to a restaurant and the food costs more money to purchase, to make for the customers. So the menu looks a little different and the pricing is going to change. And of course, everything as the economy goes is rising.
Mm.
But I feel like, as a business model, and I appreciate you being the business person. If I came to you and I said, Hallie, I've got this great business deal. So what we're going to do is we're going to work harder and we're going to charge people less and we're going to have all of our expenses go up. And I want you to invest in me. Doesn't that sound like a great idea?
It's funny. I was talking to a group of people about just all these challenges and helping people. Again, I think the economics, well, people don't really think about why that drives your care, but it does. And I had a cardiothoracic surgeon who's now retired raise his hand and say, what's so funny is I started my practice 35 years ago. And when we had 5 surgeons and 4 staff members, 4 nurses to run my practice. When I retired about 8 years ago, we had 4 surgeons and 21 staff members. And so much of that was people getting pre-authorizations for insurance and trying to fight insurance when they said no, and making sure, all the documentation under meaningful use, which came out in 2011, I believe, we've met all those criteria. And yeah, I say they're projecting. I sit on the commission, Colorado Commission for Family Medicine, and we're projecting nationally a shortage of 125,000 physicians in the next 8 years. Take that and then think about the increasing and aging population. So more demand, less supply. But I say to people, so you were told that you would be going to school and training for 12 to 16 years. And you were going to come out and you were going to have to see 35 patients a day, and you were going to have your income being cut down, and you were going to have all that $250,000 in student loans to repay. Would you jump into that occupation? Does that sound attractive to you? Um, it's a real problem. Again, misaligned incentives, they don't add up for what we need and um, what's how the system works.
Yes, I think that the expectation for us to just take whatever insurance gives us, it's this expectation that we don't have a business and we don't have to pay rent and we don't have to pay staff. And so I think I don't understand how people, I think $250,000 in student debt is coming in on the lower side now, just
Yeah.
because I feel like the cost for education is getting much, much more expensive than perhaps when I trained. And so housing is more expensive. So you come out and really you hope to have a job where you go to and you can have a mortgage for a place to live, but you still have to pay back all these student loans. And the expectation is if you even talk about money, that it demeans me as a physician in the public's eye.
Yeah.
Like I'm supposed to just not pay my staff and not pay my rent, and I'm just supposed to do whatever the insurance company says because the perception is I took a oath that I would take care of people, but it's it's financially running a business. It's
Yeah.
just a bad business model. But then on top of that, it's a no win. You can't win. And so I
Yeah.
see folks going into academia because they have a fixed salary
Yeah.
and they don't really have to deal with that.
Yeah.
And other groups like Kaiser, right? Because Kaiser has its own entity in itself. And so they own all of their buildings, they are their own plan. And so that is a self sustaining kind of process. But for the majority of healthcare, which is private practice, it it just doesn't seem to work. And the expectation is, well, you just have to keep giving. And when you run out of money, you still have to show up and you still
Yeah.
have to keep giving. It's like,
Yeah.
yeah, but we don't have a place to go and practice. And so I feel like the whole concept of private practice is becoming more and more financially devastating for the business owners, which are the physicians.
Yeah.
And that's also, private equity is now coming in, MSO groups are coming in. So all of this corporative medicine is still taking away from the patient experience, and it's again trying to get as much profit out of it, but it really isn't about getting as much patient care out of it. It's to the
Yeah.
exclusion of it.
Yeah. I mean, you think about private equity coming into the space, uh, private equities, again, not talking about any bad actors, but just what is the business model is to squeeze more efficiency and make the entity more profitable and sell it off. So what happens is we churn more staff, we try to get more patients in, we try to maximize profits. And some of those things are, good, and some of them are not helpful to patient care. And, the doctors say, this isn't really what I signed up for. But then, an individual practice really struggles to survive. I mean, there's so many things that are challenging, like as you mentioned, Lisa, to be able to run as a business. And so many of the private practice doctors that I worked alongside with for a number of years either decided to join as a larger super group or get private equity involved or be employed by a health system because it just wasn't viable. I remember there was a doc that I respect a lot, worked with for a long time, and he retired last year, and he said, the last like 8 months of my career, and he was one of the partners in his practice, I paid my staff and I paid my part of the rent, and I didn't take any money home. And, in any other industry, that wouldn't be acceptable. I don't know why it's acceptable in medicine.
I don't either. And it's also, I feel like we are shamed for even having this conversation and really talked poorly about that we're we're really struggling and we need help, and to have this conversation it gets flipped into, well, these are money hungry people. And I feel like everyone thinks this is like TV and super glitzy, and we're all just just high income, and that's not necessarily the case for
Yeah.
many practices and physicians. And I feel like, here's the thing, the nurses have at least figured out to they can step out of some of these positions and go work for private companies who then turn around and pay them more money, and they can turn around and go right back to the exact same job doing the exact same thing, but then they're paid what they're worth, and the hospital ends up paying more than if they had just taken care of their own staff. And so all the incentives to bring people into hospitals, into the healthcare systems, they're losing great people to turn around and rehire them back under a different guise. And so if you could wave your magic wand and you're starting with a clean slate and you're designing healthcare, what does that look like?
Lisa, I that's such a good question. And there's people much smarter than myself that could probably put something together. America's a capitalistic society, and that serves us well in so many things. And so I'm really torn because I've seen, we look at other countries, countries like the UK that has socialized medicine, so everybody gets health care, but then you have this gap because some of the wealthier buy their own private insurance and access different hospitals. Or you hear Canada with socialized medicine, and they we have people flying down here because they can't get care for 8 months. So, I don't know that there's just some magic systems out there in the world that has everything figured out. I think a couple things we need to look at is, should companies like a United Healthcare and some of this big pharma, should they be posting the profit margins that they are? There's big healthcare hospital companies posting margins that are just unbelievable and higher than what you'd see in just about every other industry. Should those things happen, and should those happen at the cost of patients? I think this country does not put enough toward prevention. I think we are very much based on a sick care healthcare system. And if you look at even like a country like Costa Rica, which if you just look at their financial status and their national income, it's so much different than the US, but yet they have better outcomes because they've put their efforts in sending people out into communities and doing preventive care. And again, helping people be healthy and not just treat them when they're sick. Um, you know, I really am morally conflicted with the whole how do we make so much money out of the system? I think reducing the complexity in healthcare. There are so many third party people involved in how we purchase drugs and insurance, and it creates this like veil of complexity, which is where a lot of the profit lies. And if many, I've read several articles, and there's certainly some very smart people in the space trying to do this, where if we could get bring more transparency and purchase more of our routine care like we do for cars, like go pay the money you want for your oil change, whether you want luxury where the Lexus dealership will ship you home, or you want the Jiffy Lube who can do it fast and be cheap and convenient. You shop how you want to, and then have the more high dollar catastrophe payments for like a massive car accident that sends you to a trauma response at the hospital. I think that could bring some transparency. So I think you're going to have to get people a lot smarter than me to answer that question. But I think there's some big things that we that the system veils, that drives up price and then causes this economic factor that makes it really challenging for healthcare workers to work in.
And now that you're creating your own landscape, what's on the horizon for Accessum?
Yeah,
What are your goals? What are you trying to do?
I think a couple key things. I always tell people I can't fix the system. I'm just one person, and our team is just one team. But if we can help the people so we're a membership-based company, we try, I think the term membership-based healthcare gets a bad rap. We're not trying to be available to only Nuggets players and Denver Avalanche players. We're trying to be more available to the person who really needs us. So we do advanced preventive care. And we do access to specialists as well as care coordination, nurse navigation. So that could be anything from we're helping you be preventive. There's so many more tests and labs and things that we can do where we're saying, hey, metabolically, you're starting to head in the wrong direction. You're not out of normal yet, but you're heading that way. How do we make lifestyle changes or make changes now versus waiting till you're pre-diabetic or diabetic and make those, get in and start treating that. Let's treat when you're headed the wrong way and help prevent. We work with people who, let's say you get a new Parkinson's diagnosis. You're overwhelmed. Should you get a second opinion? Should I seek care in another state where there's some of the big centers? Am I seeing the right neurologist? I can't get the doctor to call me back. My MRI won't they won't call me. These are some of the things I hear with some of our patients. We help people when they do need it and when they are sick to be able to access and to navigate. You get an insurance denial. A lot of people that just stop. Care just stops there. 850 million insurance denials a year annually in the US. So it's a recent Wall Street Journal article. Only 1% of people appeal, but 75% of people who appeal win. So the challenge is, why are those numbers the way they are? Most people don't know how. And we work with people to help get maximum benefits from their insurance when they get an appeal. how do they work with their doctor, but more importantly, how do they advocate for themselves? And so in many ways, we're working alongside a very complicated system and kind of filling in the grout of all the tiles that are sitting there loose, really helping that drive better patient outcomes and help people take care of themselves and advocate for themselves in a system that really isn't designed to do that.
I know that one of the struggles that we have with our patients is, I do breast cancer. And so we're fighting with insurance companies to get authorizations to be able to do their breast cancer surgery and do the reconstruction. And what ends up happening, this is typically on a quick turnaround from a time frame standpoint. We're not sitting around with months to navigate all of this. And so many times it's you get what you get because we're on a time gun from a treatment standpoint, and you could appeal, and like, well, you can appeal, but that could take 60 days.
Yeah.
And to tell a cancer patient, hey, you need to wait 60 days to have another conversation that may or may not make a difference, it puts patients in a very awkward position. They're going to choose themselves, and they're going to choose their care and their diagnosis, and they even opt not to have certain procedures as part of their treatment so they can simply move forward to get the most efficient, effective care right away. And I feel like having that opportunity through Accessum would be huge, where people are specialists at that. But it it allows it allows the patients to have an advocate, as opposed to having all of the nurses and doctors and the office staff trying to navigate that where they don't necessarily know that. So I absolutely appreciate that, because I know for us, there's many times where I'm in with a patient and we're right in the middle of a visit,
Yeah.
and the staffs come in and they say, "Oh, sorry to interrupt you, but we need to get you on the phone with a healthcare plan because they've denied a patient surgical care." And so, they're interrupting my patient's visit, you know,
Yeah.
and then, I'm having to fight for another patient. Meanwhile,
Yeah.
this other person who, it's their time, right? I need to be spending and focused all of my attention on them. So I appreciate that.
I know you saw that article in ProPublica where about the two breast cancer surgeons, I think in Louisiana, that sued that insurance company because the insurance company would not go in network with them. And then they wanted to do this. They were very center of excellence for breast cancer reconstruction. And so you had patients coming from out of state and people wanting to go to this center. And the insurance company said, it's way too expensive. We're not going to do that. And then patients would get this like, well, it's approved. But then on the back end, they come back and say, well, no, it's not approved. And I'm sure I'm gonna mess up these details a little bit. So the surgeons actually sued the insurance company and won. What really rubbed me the wrong way in reading all of that, because we know this kind of stuff happens all the time. But ironically, some of the executives in that insurance company had negotiated one-time deals for their wives to have reconstruction surgery at that center. And so that just always makes me go, okay, if it's good enough for your family, but yet you won't let patients get that treatment, something isn't right here.
Yes, and I've had that personally, where I've had patients who their insurance did not authorize certain treatments, and because their family members were executives, all of a sudden the the authorization didn't necessarily matter, and the cost of the products didn't matter, and it was a different set of circumstances, and all that was pushed through. But for everyone else, it's not possible.
Yeah. Yeah.
So
Take a little sip of cold water here.
well, thank you for spending your time with us today. I think this is a struggle that we have really been caught up in, and it's been years, years in the making. And I know it's going to be years into the next version. I just want to say to all the healthcare workers, we need you. The patients need you. And I also want to say to the public, we need you.
Yeah.
We are happy and are most happy taking care of you, but we have to be able to have a place to see you.
Yeah.
And I think that it's going to be a joint effort with all of us coming together and coming up with new solutions where we all can we all can do what we want to do, which is patients want to be seen and taken care of, and healthcare teams want to be present and be able to spend as much time and do the appropriate treatments for them. And so
Yeah.
I look forward I look forward to that day. So it happens sometimes in medicine, but many times not. So
Yeah.
Hallie, thank you so much for spending your time with us today. Tell us, how can we get in touch with you? If this is something that healthcare workers want to collaborate with you, or even patients want to find you, what's the best way to get in touch with you?
Yeah, a couple different ways. You can visit our website. It's www.accessumhealth.com. Accessum is spelled Accessum. It's access, Latin for access, actually. Or our phone number, 303-491-0212. So either way.
And on final closing, so I always ask my guests this. We're in medicine and there's always funny things, and just you would not believe that this happened. Tell me a funny story or funny thing that happened to you uh in medicine that no, like, we say in our world, like, you can't make that stuff up.
There's quite a few of them, not all of them appropriate, but one of one that tickled me because it's a little bit different than you'd hear about, some patient that did something weird. But, as a chief operating officer, I'm in charge of plant operations. We do everything from the fire safety to making sure all the toilets in every hospital room works. And we have the Joint Commission, which is, the surveyor that comes in and makes sure that you're following all the rules in accordance with CMS, Centers for Medicare and Medicaid. And I'm up in a room and with the Joint Commission surveyor and my director of plan ops. And we're in a hospital that, demographics a little bit poorer and a lot of gang related activity. And so we just, people there need things. And we look down and we're on like the fourth floor and there's this woman. We had these like decorative rocks outside and she's just taking our rocks and putting them into her car. Stealing the rocks out of the front of the hospital. And my plan ops director looks down and he goes, "That woman's stealing all my rocks." And the Joint Commission surveyor came and went, "Ooh, you don't see that every day." We had to do some rock replacement. Ah,
That's really funny. Well, thank you so much. What do you want to say to healthcare providers? What's your message? Nurses, doctors, respiratory therapists, all the housekeeping staff. What's your message to them?
More than anything, thank you for what you do. I'm just so grateful to have worked alongside of really wonderful people. But everything we talked about today, try to push that out of your head and keep focused on why you're there, which is really to impact the patient and to take care of people because that work is so meaningful and that's what you can control. And it's hard. There's a lot of days where you got crabby patients or, yeah, I got to see more people. I got to be busy, but um, try not to lose the focus of why you got into healthcare because we need you. As you said, Lisa, we need good people to take care of us, especially an aging population. And most of the people that get into healthcare are good people.
Yeah, thank you. Well, thank you, everyone. Thank you so much for joining us today here at Soulful Surgeon. I look forward to our many conversations. And if you have any comments, please drop them for us to take a look at. And if you have any suggestions or any concerns that you want to talk about on the podcast, please let us know. Thank you so much. I'm your host, Dr. Lisa Hunsicker, your Soulful Surgeon. Take care. Thank you for joining me on the Soulful Surgeon Podcast. I hope today's conversation offered you reflection, encouragement, and a reminder that you are not alone on this journey. If this episode spoke to your heart, please share it with someone who might need it as well. And don't forget to subscribe so you never miss a moment of connecting with healthcare workers all over. You can find us on the web at soulfulsurgeon.com. You can find us on Instagram at Soulful Surgeon. And you can find us on LinkedIn at Lisa Hunsicker, MD. Until next time, take care of yourself the way you care for others. And remember, your story matters here.